welcome to the Terminology Leading Practices stream at the SNOMED CT Expo 2025. Thank you to TermMed for sponsoring this stream. My name's Elaine Wooler and I'm a Senior Terminologist at SNOMED International. I'll be your moderator for today's session. We'll address any questions at the end of the presentation. For our online audience, please use the Q&A button to submit your questions to the presenter. For those attending in person, feel free to use the microphone provided in the centre of the room when the time comes. It's now my great pleasure to introduce Kristel Van de Loock from University Hospitals Leuven, who will be presenting Standardizing Rare Disease Registration, a SNOMED CT-Orphanet mapping approach in the electronic patient record of University Hospitals Leuven. Thank you, Kristel, over to you.
Thank you very much. So, hi, I'm Kristel, but I have already been introduced, so I can skip this slide. I work at the University Hospitals of Leuven here in Belgium. It's a large university hospital, and it's one of the 8 Belgian hospitals which has been recognized by our federal government as a rare disease center of expertise. That brings us to the rare diseases. What is a rare disease? A rare disease is a condition which doesn't affect a lot of people. So in Europe, it's defined, a rare disease is defined as having a prevalence of less than 1 per 2,000 persons. Approximately 30 million European citizens are known to have a rare disease. There are already more than 6,000 rare diseases known. Unfortunately, many of them are underdiagnosed. Since of their rare character, it's also always a challenge to capture the rare diseases, so it can take a long time for patients to get the right diagnosis. Unfortunately, the data on rare diseases is very fragmented, which makes it difficult for care, research, and policy. So needless to say that coding of rare diseases is very essential. The history in our hospital, of course, also a very fragmented data collection. Every clinician seeks their own path to capture their rare diseases. Several of them were also requesting for Orphanet coding to be able to directly code Orphanet codes in the electronic patient records. Our electronic patient record doesn't support Orphanet codes, so their request was not an option. That brings us to our current vision. We're full-on coding in, we full-on want to code in SNOMED CT as primary language in our electronic patient record. We want to capture all diagnoses, not only the rare, but also the non-rare. And for this, we want to use one language to avoid confusion, just to keep it feasible. Just a clinician doesn't need to know in what language he's coding, he just needs to know I have to code at this place, in this one location, and that is the problem list. As you have heard through the past days, also Belgium, our federal government, is really putting their efforts into getting SNOMED CT as a primary language in the electronic patient record. And also the European Health Platform recommendation and the EHDS recommendations for 2029 are upcoming. So we are confident that SNOMED CT is a good choice to make to primary code in our electronic patient record. So what was the project goal to capture our rare diseases? Of course, we wanted to align with the vision of our hospital and enable a structured diagnosis coding using SNOMED CT. This is for all diagnoses. So we're currently working on this project. It's an ongoing project, yet not finalized, unfortunately. But by setting into this one language, we want to support clinicians in their daily practice. Of course, coding in one language brings a challenge because we need to extract rare diseases. And for this, we are using the SNOMED CT-Orphanet map, which is made through a collaboration between INSERM and SNOMED International. This way, by coding, we want to provide high-quality data for care, research, and registries. Here in a nutshell, our current workflow, I will specify the steps more in detail later, but in the back end of our electronic patient record, we only store SNOMED CT codes. Then our clinician registers these SNOMED CT codes directly in the problem list of our EPR. After the registration is performed, the data is extracted to our data warehouse with other clinical data. In our data warehouse, we have stored the official SNOMED CT mapping together with a small own UZL rare disease map. And then we transform our coded SNOMED CT data to ORPHA codes. So the background, the one language. We have two paths. We have a current project to capture all diagnoses in SNOMED CT, and therefore we're currently talking to a lot of clinicians to say to us which diagnoses are relevant. Since SNOMED CT is huge, we do feel the need to have a selection of the diagnoses for our clinicians. These are rare but also non-rare diseases, these diagnosis lists. And they are under supervision of our clinicians, co-developed with our terminologists. And on the other hand, because our clinicians of rare diseases really made a cry for help because they needed a coding system, we also imported the 6,700 diagnoses from, in SNOMED CT, which are currently available in the Orphanet SNOMED CT map. On the right side, you see a small example of a specialty-specific diagnosis list we made for our doctor for primary immunodeficiencies. Then we have our lists. Now the clinician has to register. Our doctors have two options in the electronic patient record to capture diagnosis. They have a search engine, which functions on all SNOMED CT synonyms that are available in the international version and in the Belgian version. And we also have a tile system, buttons they can click through to select the correct diagnosis. Of course, these buttons can only be made for our specialty-specific lists because they are built together with the clinician and they say what's logical for them. On the left bottom side, you see another thing we can do in our system. We can also do a light version of post-coordination. It's all custom made by the terminologists in-house. And if the clinicians say we need to add some extra info for our diagnosis, we have the option to post-coordinate according to the SNOMED CT concept model, certain attributes to capture extra info about the diagnosis. Then, when all the data has been recorded, we go to our data warehouse. There, our IT department custom built a dashboard for rare diseases to extract our patients with rare disease. So in the background, we have the SNOMED CT-Orphanet mapping and a small own UZL rare disease list. Yeah, this list has been built through the dialogue of the specialty-specific diagnosis list we're making. So we check there and ask our clinicians, are there any extra rare diseases we should take into account from this specialty-specific list? Of course, we realize the challenge by registering one language that we have a risk of underreporting our rare diseases. The current mapping is a one-to-one map. And we do notice that Orphanet has also its own structure of these groups, disorder subtypes. The disorder group is well mapped. It has a 95% coverage, but we do miss a mapping in the subtype level. And certain clinicians often say that those subtypes are also clinically relevant to capture in the EPR. Therefore, we did a one-time exercise in our hospital to try if we could expand the official mapping using the SNOMED CT hierarchy. It's a one-time exercise. We didn't really, small disclaimer, we didn't use it to report to any registries or something. It was just a theoretical exercise to see what would happen if we do this. So we have our hierarchy, and we would check with all the SNOMED codes, is this disorder mapped to an ORPHA code? Yes, then it's a no-brainer, of course it's rare. No, then we would check, is one of the parents of this SNOMED code mapped to an ORPHA code? If that would be yes, then we would conclude this subtype of that ORPHA code mapping is also a rare disease. And if we wouldn't find any rare disease in the parent structure of the hierarchy, we would conclude it's a non-rare disease. So, of course, we all know SNOMED is a has a polyhierarchy. And of course, you can have multiple parents which are mapped to an ORPHA code. So for this exercise, we use the depth of the mapping in the SNOMED structure from the transitive closure table. And we would conclude that we would map a child to the lowest parent, lowest in depth. So in this example, the ball would be mapped to the parent with the depth 1 and not with the depth 2. This one-time exercise expanded the mapping with 10,800 SNOMED CT concepts as rare disease. And 20%, we also ran it theoretically through our database, and we found 20% extra rare disease patients in our database. I must say this is an old exercise from 2024, so maybe currently it can be different. There are other challenges we're facing. SNOMED has a monthly release and the mapping is yearly updated. So we do feel the risk that there might be a delay for capturing new rare diseases. Also what we miss, our clinicians miss, this is an example. Our doctor also wants to capture the gene which has been affected causing this rare disease. Unfortunately, the genes aren't presently available in SNOMED, so I'm afraid currently we're just letting her type it in free text on the bottom to capture somewhat about the genes. As I said, we also have a small UZL rare disease list. Of course, that also need maintenance and continuous validations, which also is a challenge, of course. For future directions, we would like a faster mapping cycle instead one time per year. We also would love a better Orphanet subtype integration in the mapping. Currently, our federal government, our NRC, is investigating the possibility to do an extended mapping on the Orphanet codes, but it's still under investigation. So maybe we can hope to see it in our own extension. Also, we would love to see genes in SNOMED CT, so we can link them to our diseases. And of course, with these, we hope to reach a better interoperability with research networks and registries. To conclude, from UZ Leuven, we do feel that we took the right path, coding in one language. We are a university teaching hospital, so a lot of our residents there also are coding diagnosis. They don't all know about rare diseases. They don't always are aware this patient has a rare disease because they are biased because we are a rare disease expertise center. They sometimes don't realize it's a rare disease because they see it so often. So we think it's good that they have to code in one language. They don't have to think from, now I have to go to my rare disease list to code a rare disease. And now, so we have a uniform system. We want to capture all diagnoses, so we don't want doctors to think anymore, just, yeah. Sorry. Bad expression. No. We don't want to think about the way of registration, so that they just register all diagnoses. Of course, with the one language, the mapping is crucial. We love the SNOMED Orphanet mapping, but we want to see it more expanded. That would make our work so much easier. And we do feel that this pragmatic approach could be scalable to other hospitals. I also want to thank our team, Professor Marion Delcroix. She's the chair of the Council of Rare Diseases, Elia Eskes as our coordinator for rare diseases, and my fellow terminologists, Celinde Bartholomeus and Kim Huygens. Thank you all very much for your attention, and if there are any questions, I'm happy to answer them.
Thank you very much, Kristel. Okay, if we got any questions in the room, please feel free to use the mic.
Yeah, thank you for the very nice presentation. I have a question actually, because if I'm correct, in rare diseases, you often also gather functional data, because lots of diagnoses initially are made in a first step based on clinical investigation, for example, pain and all this kind of elements. And I'm wondering if you also have experience with mapping this more functional data, because we're actually doing for the Belgian Terminology Center a project on mapping ICF, so International Classification of Functioning, with the other way around, from SNOMED to ICF classification. And we're looking at solutions for functional elements like being able to walk, pain and all this kind of stuff. So I'm wondering if there is experience on that field also, but maybe not, and that's okay then.
Yeah, for this project, no, not really. We're still really focusing on diagnosis, so we first want to be able to capture them. But we do have another project because of the data capabilities project, and there is the nursing that's maybe a little bit related.
There is for sure an overlap.
And there we have a mapping of our, I don't know it in English, maar onze verpleegkundige definities are in our system that we have mapped to SNOMED, a small part of them. So
that would be interesting one day to explore that. Thank you very much.
Thank you.
I'm Pedro from the Belgian NRC. So just one quick thing is the genes are going to be mapped to SNOMED. There's a project that has been launched recently. It was announced in the business meetings.
Good to hear that.
Yeah, so it is coming. We don't know when yet. Mainly limited to the genes that are used in diagnostic tests. That's not going to be the whole, thousands of genes. So that's we can get you more information of that soon. And another question: is your ambition to expand SNOMED by adding more content that's missing from Orphanet? Concretely, what do you keep track of the light post coordination text that you showed there? And could that be used as sources for new concepts?
I don't think that for the post coordination, I don't think we really want to immediately add new content, because our clinician likes it this way. They want a main diagnosis, and that for them that's the essence, the main diagnosis. But then they want to capture some extra elements, and it comes later in the process, so they then add it on. So they like it to open it and add it. So I don't think that will be the scope, but we do have clinicians who miss diagnosis in both languages. And then we try to request them with international, and we send it, and our rare disease coordinator then sends it to our contact with Orphanet to also add it in the Orphanet content. So there are gaps, of course, yeah, because it's always evolving in medicine. So I think that's normal, that we are sometimes missing the certain things.
Hello, thank you for a very interesting presentation. I am Marte from the Norwegian NRC. I used to work with rare diseases as well in the National Center, and a lot of the smaller countries in Europe probably have the same problem with rare diseases patients. When you have a small population, you can get a rare disease in a patient that you've never seen before, and you need to contact a physician in England or in Germany to just see how do you actually treat this patient. We've never seen it before. I think what you're doing now is a very good basis for maybe a bigger Nordic, European, or international cooperation about rare diseases? Do you have a larger thought process about that, or are you thinking more locally?
I didn't, but it sounds really lovely, yeah, if it would be able to expand, and we do feel there's a lot of work in keeping the identification of the rare diseases, so if we could more centralize it, that would be great, yeah.
Thank you, great.
My name is Kengling Balin from the Swedish NRC, and I really second that suggestion because I've been talking to the Swedish Genomic Center, and they also have been discussing, in fact, they were wanting to know, we were discussing, okay, what we kind of code systems to use. They are used to Orphanet, they use Hugo, they use others, but SNOMED is new, and they are asking why SNOMED? So by creating a community need, you can see the users. In fact, they asked me, is it used in anywhere in the world? We would love to connect with them. So I think that was very highly motivated.
Thank you. Yeah.
Thank you for the very interesting talk. Are you thinking of putting your data in a SNOMED CDM database, and then we could join them in a federated way all over Europe?
That I need to discuss with our IT department. But I don't know, yeah, I'm not a technician on that side, so I don't know why you choose OMOP or FIRE, but because for them, I thought we were now a lot of to go towards FIRE, so I don't know why you're just suggesting.
You can have
OMOP.
both.
Ah, okay. Yeah, that I need to discuss internally. I don't know how we should practically.
Because that would be interesting if you then are in Norway and you see your patient with a rare disease once in your lifetime. You do a federated query, and in Leuven, they might have 2 or 3 or 5 of them.
Yeah.
And then you can make a phone call to Leuven or send an email. Could we talk about this patient, GDPR, compliant, etc., etc.? But then we would find all the patients wherever they are in Europe.
Sounds great.
Thank you for your great presentation. I would like to comment that we have 6 expertise centers mapped to Orphanet and SNOMED through our diagnosis thesaurus. And we collect the data from those expertise centers, and we show it in a dashboard, an Orpha viewer, we call it, so they can track their patients. So we welcome you to make contact, and we can show you how we did it.
That sounds great. From where are you?
From the Netherlands, sorry. I'm from Dutch Hospital Data, and we are collaborating with the expertise centers for registry of Orphanet, Orpha codes.
Yeah. Thank you.
I just wanted to add, so my daughter's disease is very rare, 1 or 2 in a million. And being a pharmacist, I was also wondering, what if some pharma company would like to do research on this disease and create a drug so that she does not need a liver transplant? And it was very hard for me to say, where should I register to say, hey, I'm here with a rare disease. If you want to do research, please pick me. And so that could also be interesting to maybe anonymously, of course, but to say, like, we have patients with this disease. If you want to do research, you can reach out. So what I did was registered on an American platform, Patients Like Me, which is actually to find other patients and to talk with other patients with the same disease. And in the last 7 years, 2 American companies have contacted me to hear the story, to get not even data, but really like talk to me to know more about the disease. And now there are 2 drugs on the market already with CRISPR technology or something. So just to say that it's important to be able to be found with a rare disease. Thank you.
Stalas Carlinus. Just to add to that, I think this is will be the responsibility of the European Reference Network. So they're trying to at least make a cartography of the whole European, all the countries at least, to have an idea about which reference center is linked to which rare disorder. So at least we will try to build a cartography to make at least have an idea about where which expertise is centered in which center and which country, etc.
Okay. Thank you very much. Thank you very much for all the questions as well. This is what these conferences are all about, and I think for something like rare diseases like this, making these connections is even more important. So thank you very much to Kristel. Thank you.
Well done.